Good afternoon, everyone. It's nice to see the room still so full at the end of the day. I know it's been a long day, but I think there's been some excellent discussions. So let's keep it going with our session today on health data as a catalyst for policy innovation. So we find ourselves actually right now at a pivotal moment with the creation of the European health data space in the near future. And EHDS is how we're going to be referring to it from now on. If you haven't heard that before, we love acronyms here in Brussels, so that's what we're going to go with. So EHDS, basically, it's given us the chance to move from isolated data sets and fragmented systems to a shared foundation for clinical care, research, policymaking, and innovation. Health data is already transforming how we detect outbreaks, tailor treatments, and design policy, but the potential becomes a lot greater when we talk about a trusted, interoperable, and secure baseline for access to this data all across the EU. Improved access to health data will be an enabler for smarter policy, stronger health systems, and more inclusive, equitable access to innovation across Europe. So our speakers today will bring perspectives from regional innovation ecosystems, hospital networks, digital health governance, and cybersecurity to have a great mix that will help us unpack both the opportunities and the practical realities of making health data work for people and systems. So help me join me in welcoming our speakers to the stage. We have Dr. Iñaki Gutierrez Ibarluzea, sorry. He's the Director of Health Research, Innovation and Evaluation at the Basque Government's Ministry of Health. We have Mr. Marc Lange, Secretary General of the European Health Telematics Association. We have Professor Johan van Elderen, the Secretary General of the European University Hospital Alliance, Ms. Maria Papafilippou, Cybersecurity Officer at the European Union Agency for Cybersecurity, and last but not least, Mr. Guillaume Bic, Legislative Officer for Digital Health at the European Commission. And this is on, great. So Guillaume, I'll let you get settled because I'm gonna come to you first, so I'll have you grab the microphone. There's a microphone right there for you. So I'm gonna have you get started. I know we just had, some of you were probably there, a session on specifically the EHDS, and funny enough, that's exactly what you're working on. So can you maybe just set the stage for us, share with us a little bit the work that you've been doing from a legal and policy perspective, and I know a bit of implementation as well on the EHDS, just to help us all have a shared understanding of where we're at with it and what challenges you're facing and what stage you are in the implementation process.
Okay, thank you very much. As you say, I mean, it's been an adventure for sure. It's really much, the EHDS is really much children of the COVID crisis, I mean, that's for sure. So what happened there is really, with the COVID crisis, you actually saw the need for having a common European framework to share data both for primary and secondary use. So it would have been very nice to have this kind of framework made available during the crisis, and hopefully now with this tool, I mean, we should avoid this kind of fall. So, of course, there was the first stage, which was the negotiation of the regulation. Now it has been adopted earlier this year, and as you said, we are starting with the implementation phase. I mean, it's a very ambitious implementation phase because basically we need to have something starting within 4 years with some additional element, 2 years, additional 2 years. So it's a very ambitious plan. There's quite a lot to do, especially for secondary use, because there the system is very much need to be put in place. Well, for primary use, there's already a voluntary system being made available, but of course, every member state needs to be put on board with this system for primary use. And that stage at the moment, I mean, we have started, you know, the implementation phase with comitology and all these processes with implementing Act. We also have ongoing research project and collaboration framework to make sure that we feed the information for this implementing Act, and slowly with each information and with a review of what's needed at what time, we've slowly got to move all these elements out of the gate to make sure that we are ready when we need to be ready in 4 years' time.
Great, thank you for setting the stage for us. And we'll come to Mark, so if you want to pass it down the line. I think, Mark, you might be in a good place to carry us forward, because we obviously will have access now to unprecedented level of health data, but how do we make sure that clinicians, hospitals, and innovators, and the entire ecosystem really is actually able to use this data effectively, efficiently? What do we need to do? What changes do we need to make? What needs to be in place?
Well, straight to the point and straight to the core of the topic. The reality here is that, but first, I'm representing here Interoperable Health Telematics, and it's an organization working with and for implementers on digital health since 25, 26 years. So the network of people we are working with are really those you are mentioning, and for them, there is no other solution that for each of them to get something out of it. And that's really the question. I mean, if I can use an image that was used at the time of the e-government, so 20 years ago, we are building highways, and that's great. That's indispensable. But for the highways to deliver value, we need cars, we need trucks, we need business, and so on. And that's what is really needed for the clinicians, for the innovators, for everyone to get value out of this highway.
Great. And I'll come to you, Iñaki, because I think we have, at the high level, the idea that health data can inform policy, but as well, we come down to the regions, and the regions are the ones who are really implementing these policies. And I wonder what experiences you maybe already have with working with health data, and what you might look forward to by having more access to better data over time.
We as regions, we still think that we are countries. I was laughing because we are talking about different type of responsibilities when we are talking about healthcare, and when we are talking about who in reality are providing the services in most of the nations in Europe, they are the regions. So as a whole, so in most countries, even not being called federal countries, they are the regions. So what I think, and that depends also on the size. I'm used to say that we are the full Baltic country because we are the same size of Latvia, Estonia, and Lithuania. Probably Tit will laugh about that because Slovenia has the same size. Well, so we are 2.2. The European health data space has been for us an opportunity because I was explaining in the previous and the parallel session that for healthcare systems, one of the things it is having spare money for investment in things that are important for the healthcare systems. It is quite difficult. Why? Because you start the very beginning of the year, and at the I would say first week, all the money is gone, because you have already many commitments that have been precluded in previous years. So it is obviously paying the staff, paying for the drugs that we are in need to provide to citizens, maintenance of hospitals, connections with primary care, and many other things. So the money is gone. So the 7th of, I was explaining that the 7th of January, at least in Spain, because the 6th is the Wisdom Kings and the kids receive the gifts. The 7th of January, the money is gone. So the European health data space has been for us an opportunity to talk together different ministries in my government. Why? Because they were saying this is an opportunity in terms of using the data for other purposes. And that was the first time ever that I've seen the Ministry of Science, the Ministry of Industry, the Ministry of Governance, and the Ministry of Health talking together, saying this is something that could be of the interest of all of us for different things. From the side of the Ministry of Health, we need to solve the problems. That is making decisions, not flipping the coin. So that is the first idea. Second, trying to do the best with the things that we are doing. So this using the data in terms of improving the healthcare, the quality and the outcomes. And the third thing, obviously, it is related to bringing value to the investments that we are doing. And we are far away from having sufficient, I would say, return on investment on the things that we are doing. There were a couple of articles that they were saying that based on the budget that we are spending, more or less 25% of the budget is going to, I would say, to rubbish. So it's, we need to be much more efficient. And the fourth thing, that was what has put us in common, that is technology development. So we have questions from the systems, and we have burden of disease that is not covered with current treatments and diagnostics, and needs to be developed in a form of a technology that could solve the questions that we have. So on that basis, that has been the use case in which 4 ministries in our government are working together. And the European health data space has been an opportunity because probably for most of the citizens in Europe, probably they are not knowledgeable that most of the data that we are collecting by regulation or by law, we are not using to make things happening. So we are not planning on the basis of the data that we are collecting, but it is because we don't have the mandate. We don't have the law up to now. We don't have the regulation that gave us the chance to use them. And for us, the European health data space and the opt-out circumstance has been a trigger in many senses in terms of calculating that.
And it makes sense because we have this aspect of all of this data kind of coming in a very short period of time, right? So there's a lot of different aspects. We maybe don't know exactly how to use them. So Johan, I'll come to you actually, because obviously hospitals and clinicians like yourself are big generators of a lot of this clinical data. And I assume at the same time, you want to have a bit of symbiosis. What do you expect, or what would you expect for hospitals to get back from giving the data and being able to use it in return?
Well, first of all, let's say we are an alliance of 11 university hospitals. We are completely in favor of the European health data system. Let that be clear. On the other side, and I don't want to rain on the parade, there are maybe more obstacles to going to interoperable data platforms than most people would imagine. But clearly, we see the advantages. And the advantages for hospitals will be very big. There would be advantages, let's say, in the short term, in increasing the efficiency, in implementing low-value care, in being better prepared for external threats. There would also be long-term advantages that would come from analyzing these enormous sets of data that we have, and that might lead to completely unexpected new ways of diagnosing, of curing diseases, of preventing diseases. So we're absolutely in favor. But let me come back to this, the first thing, and that is to make the data interoperable. And that is not only a question of having software that can talk to one another or translating all the data into a common data model, such as the OMOP, which seems to be the most used common data model for secondary use of health data. But it's also the way in which we record a lot of the data. And I'll give you one example. We did a benchmarking study on breast cancer in our alliance between university hospitals. And to, first of all, get the clinicians to agree on what would be the right data. And then second, to have the data managers agree on how to define the cohorts. It took us 3 years. And just to give you one example, for example, one of the parameters of a good treatment of breast cancer is sentinel lymph nodes taken out of the axilla to see if the cancer has spread. So there are international guidelines that say you need to take less or more than 5. So we use that as an indicator. But then it appeared that in some hospitals they say 1, 2, 3, 4, 5, 6, 7. In others they say less than 3, more than 3. In others they say less than 7, more than 7. That for data managers is a completely different situation. So there's a lot of effort that we will need to do to make sure that we record the same things in the same manner with the same indicators. And that is a part of the work that I think has not been sufficiently thought about.
And indeed, I think that's a big theme from the whole day is how do we all speak the same language? How do we get on the same page about being able to work with the same data in the same way that actually makes sense for everyone? And I think another challenge that we haven't addressed yet is, maybe Maria, you could speak to this, is the issue of security. The more data that's out there, the more we need to make sure that it's protected. We're asking people to put their data into a system. Obviously, maybe it's not their personal data, but at the same time, there are new vulnerabilities. I wonder if you could share some of the work that you've been doing with NISA and maybe the history of health data security and how it's evolved in your work.
So, first of all, how many of you have heard of ENISA before this morning? I thought so.
NISA.
The EU Agency for Cybersecurity. I work at ENISA's Resilience of Critical Sectors unit. ENISA well, our mission is to achieve a high common level of cybersecurity across the Union. And we received a permanent mandate back in 2019, the Cybersecurity Act, which establishes our activities. And our main driver and enabler is the NIS2 directive. So the NIS directive includes some baseline cybersecurity measures relating to critical infrastructure sectors that rely on information and communication technology, and on which sectors the stability of the society and economy depend on. So what we do, basically we aim to enhance the cybersecurity maturity of these critical sectors, and of course, one of the sectors is health. So we've been working in health for a decade now, and we have published a number of reports over the years, like procurement guidelines for cybersecurity in hospitals. We've published reports on resilience of smart infrastructures like hospitals, cloud security for health. We released a dedicated threat landscape for health back in 2023. We also published bi-monthly situational awareness reports, which include the threats to the sector specifically. Well, another important initiative is the Cyber Europe back in 2022. Well, Cyber Europe is the pan-European cyber crisis exercise organized by ELISA. And back in 2022, the scenario focused on health, so we aim to test the resilience of the health infrastructure across Europe. And the findings more or less confirmed what we had already known about the sector, namely that the sector is a bit, well, not as prepared as other sectors, let's say, for cyber crisis. And together with Cyber Europe, we also launched a targeted awareness campaign for the sector, because we realized that awareness is key both for the at board level, but as well as for medical staff. Because of all that work, I guess we are all here today to discuss the EU data space, but as well as, I'm not sure if you're aware of the EU action plan for the cybersecurity of hospitals and healthcare providers. It's a plan released by the European Commission that foresees ENISA's assistance to the member states in order to enhance the cybersecurity maturity of the sector. It includes several actions which we translated into services to be provided to the hospitals and the healthcare providers. So there's also a long way ahead for our work in the health sector. I'm very happy to see you all here, and especially at the end of the day. I know how hard it is to keep a full room at the end of the day. I do hope that we can all collaborate. It's crucial that all the stakeholders in health collaborate to enhance the cybersecurity maturity in health. So this is our main objective for the next years, for the years to come.
Well, it is comforting to know that there's a specific action plan for hospitals and healthcare. That's a bit of a surprise to me, but a positive one. And I'll come back to you actually, Guillaume, because we talked about, I think, Johan, you touched on it quite well, the idea that implementation will be the key factor of success. We can have all of this data, but if we don't have agreement on how it can be used and how we incorporate it into our systems, then it might be a challenge to say that we've used it effectively. So I wonder what you think the biggest challenges will be for member states and their health systems as they try to incorporate the EHDS into their processes, and what support the EU is prepared or ready to offer to them to help with the transition.
I think there, I mean, the problem we have is a different maturity level you have in different member states. And we also expect in the previous discussion about the EHDS is that you have member states which are quite advanced and some member states who are not that advanced. And one interesting thing there was said was that it's important to with all these member states, I mean, there are systems in place for member states to work together on the implementation, so that they see the best practice of the member state, but more importantly, they also see the path not to be taken, I mean, the wrong example that they should try to avoid. So that should actually speed up some of the member states which are not at the same maturity level, and going more quickly to the right direction instead of actually taking the wrong turn once in a while, which is normally the learning problem. So there are, I say there's a lot of elements there to ensure, to help out, and also the Commission is trying to help them out also with providing, funding projects, funding common initiative to ensure that this process can happen and can feed on the implementing act that are needed to design the framework. So that's really about it. So we are very much always in contact with the member state. Of course, we also, as here, we're also in contact with all the stakeholders to make sure that everybody hopefully move in the same direction to ensure that, we do end up being very prepared and actually to manage to actually complete the required element and put them in place within the set time frame within the regulation.
And so that's a bit of a top-down approach to support. So I'll come to you, Iñaki, and I wonder, because you said we did not have the mandate to implement some of this data. So is there some support that you might ask for from the European or the national level that would help you implement or use this data a little bit better? Or is there some support that you need?
Yeah, we were discussing also in the previous panel. One of the things that is required is, especially in those places in which we weren't mature enough in terms of the development of the catalogs and so on. So it's, in our case, we made a transition for many of the things that are precluded in the European Health Data Space mandate, that is establishing a single electronic record for the whole population at the different levels, so this all the professionals have access. So we did investment, we have the catalogs, but there is still a transition that needs to be made, that is be prepared for secondary use. And I think that transition was not pretty much advanced. So in the discussions that we have had, there are three things that are tremendously important. One is governance, so it's how the uses are going to be, I would say, controlled. So it's traffic control and which are the objectives that they are going to preclude. Second thing is structure. So it's healthcare systems, and I'm looking at hospitals. They are prepared for primary use, and not in all cases, I would say. So this we have nowadays a huge problem in attracting talent and retaining talent in terms of data engineers and all those professions that are needed in terms of use of data. And we are not competitive in comparison to the industry, and that is another thing. So once they are trained in the healthcare system, then they fly to the places in which they have better salaries and all the things. So structure is a factor that is not in the equation, or that was not in the equation. And the third thing is investment on infrastructure. So this in our case we did quite a big investment in infrastructure in terms of making interoperable all the data, and that was done so many years ago. So from that side we are quite covered, but in terms of the structure we are not at the place that we should be. The good thing is that I would say the cautions. So in a government you You have your own mandate, and you have some courses that are in the surroundings that are the Ministry of Finance, the Ministry of Science, and the Ministry of Industry. So, and they have the money to invest. So for us, it has been an opportunity showing that they are going to be partially the users, and they are in need to pay for the infrastructure, and also think about how the structure will be established. And for us also has been an opportunity, and I'm following the comments from Johan, also to think about what we are going to measure in the healthcare system. Up to now, and in most cases, and it is, if you go to the political campaigns, most of the things that have been discussed in Europe, they are useless in terms of finally the health outcomes of citizens, because we have been discussing about waiting list, we have been discussing about length of stays, we have been discussing access to the first consultation, and we are discussing about lack of professionals. If you look at those things in reality and how that affects the quality of life and the life expectancy of the citizens, well, some of those they could be related, but not in reality. And we have been concentrated to measure things like health outcomes and value for investment. That I think it is. And in most cases, and once again, I'm looking at Johan. Also, we have been also struggling managers of hospitals to use KPIs that they think that they make no sense. So and the incentives also for the systems in terms of recording those data that finally are important for planning, they are important for advancement, and they are important for improvement. It is almost none. And most professionals also are telling us that why they are recording some data when those that are in need to make decisions, they are not using the data. So I think we need to, in the European health data space, it is also an opportunity to think about what are the data that we need, which are the purposes that we have, and how that will be recorded. And in the previous panel, we were saying that there are different levels of maturity in different countries and regions in Europe, and I'm in agreement. And I was saying that lack of maturity is an opportunity, because we are not going to make the same mistakes that I've done during the last 40 years. So if we are sufficiently clever to establish which the purposes of the primary use of data and secondary use of data, perhaps we are going to have a much more, I would say, fit for purpose system in which we are collecting the data that is needed to make decisions at the different levels, and at the political level in terms of and at the political level and based on the context. So all the actions that we are going to make, they are not going to be the same in all the contexts in Europe. Although we think that we are going to make the same decisions, it is not true, and it would be a nonsense. Second, it is from the side of the professionals, because they are going to have the sufficient tools in terms of being or having at least tools that are support the decisions in a better and a more efficient way of doing. And the third thing is the patients and the citizens, because we are on the basis of data, we are going to make something that we were supposed to do in health practice, that is share decisions. And we are far away to do shared decisions on the basis of information right now. So I think it is a reflection. So it is good luck for those that are not mature enough, because they have the path much easier than those that we studied. I would say some decades before, and hopefully they are not making the same mistakes.
And I think that's also a good point that you make about we need to reach patients, we need to reach clinicians, we need to reach policymakers with the importance of this idea that health data can be a catalyst for improvement across the health system. But of course, it comes down to sales, it comes down to money. So maybe, Mark, if you want to talk a little bit about how we can reach different stakeholders. We all speak different languages. You'll have someone, I think you mentioned the ministries of industry and investment, they're not going to be interested in the same things, for example. They don't want to hear the same arguments. So how do we tailor the way we talk about health data to different groups so that we can get this message across and really pull in the cohesive effort that we need?
Well, I'm back to the initial point that I made. They need to get something for them out of the data that they are manipulating. And of course, everyone has different interests. And I would even say the industry has a different interest, which has to be respected too, because they are developing the business. So they also need to have to get value from the data that they are sharing. That's as simple as that to be said, but to make it happening, that's much more complex. You have this example that you gave on the semantic interoperability on how to not, it's even not, but how to code the data. It's even not semantic, but it's also you have also the question on how to ensure that the same data has the same meaning in different places. And last point, first of all, that's what I would like to make, is that you need also to understand and to be aware of what is the context data has been produced. Because either it has been produced in the context of caring a patient in a certain disease or in the context of prevention process, the same data will be interpreted in a very different way. So this is a lot of work that needs to be done to homogenize or to homogenize the data, speaking the same language as you said. The question is how and where to do that. And of course, today, data are there, and then you process the data with tools, with process to prepare them for secondary use. But in the end, that's create a big disconnect between producing the data and then reusing them for secondary purposes. There is much more advantage to streamline this, to have the data being properly collected and produced at the production point. But then, to do that, you cannot ask clinicians who are producing the data to do all the work for the others. They will never do that, and that's very clear to be very understandable. So they need to get tools, they need to get support in order and to have to set the right context. So in the hospital, at the organizational level, at technical level, at time management level, they need to have the necessary support to provide the standard of the necessary quality and with the right meaning and in the right context.
And Johan, I think I'll ask you to take us to a world where all of these challenges have been overcome. We've found a way to speak the same language. We've found a way to homogenize the data, and we found a way to get the right investments. So in a hospital setting, for example, if we have all of this working properly, what in your ideal scenario does that look like? How does that help patients? How does it help your clinicians and other staff at the hospital? What are the best uses of data and how that can really improve your processes? I know it's a bit of a complex question, but we'll ask you to imagine this world.
Christmas, so there's different levels. Surely, and I think this is fairly easy to obtain, well, relatively easy to obtain, is to improve the efficiency in our hospitals in terms of the implementing low-value care, preventing antimicrobial resistance, better infection control. These are easy targets. The economical evaluation of what we are doing is another advantage. But I think what in the longer term would be the most important outcome is when we have this massive amounts of data that we get completely new therapies or treatments of diagnostics that we haven't even dreamt of, that are outside of our box today. And that hopefully with the use of these vast amounts of data and the use of possibly artificial intelligence, maybe it would show us completely new ways of doing what we are doing today. So that would be my ideal scenario. But again, I think there are still some initial conditions that need to be fulfilled, and I completely agree with the previous speakers in terms of convincing doctors to do this kind of work. I don't have to tell you that our healthcare systems are already overburdened, and to ask our doctors then to put more structured data into electronic health records, I can tell you there are easier things to tell doctors and nurses and paramedics than that. And then to have the data managers, as already mentioned, I mean, it's incredibly difficult. We don't have them, we can't find them, we can't pay them enough. And then the cybersecurity is another issue. I completely agree. One of our hospitals was visited not long ago by an Israeli firm that deals with cybersecurity, and they told the CEO that any 18-year-old Israeli with a basic knowledge of computer would hack into his system in about half an hour. So there are so many challenges at this moment in healthcare, and I think it's only when we get support both at the level of people that can help us reaching this point, but also in terms of convincing people of the urgency of this problem, that will really be needed to make this a reality.
And I think indeed that's the power of the dream, right? If you can think of the ideal scenario, I think it's a bit easier to sell someone on investing and overcoming some of those challenges. So thank you for sharing that with us. And with that said, I think that might be a good moment to open it up to the audience. So similar to other sessions, if you have any questions, I would like you to raise your hand. I'll come over. And if not, we'll continue. But please, I'll give you a second. And perhaps we've had all the people willing to ask questions who did so in the last session, but that's okay. Maria, since we are on the topic of hospital cybersecurity, I'll come back to you because I think the idea of what a perfect cybersecurity system might look like in the hospital is quite complicated. And I think, as we've heard from all of our panelists, it's a complicated topic across the board. But if you're talking about designing a cybersecurity system at the national or at the hospital level, what types of considerations do you need to discuss? And maybe you could share some of the challenges that you're facing right now when you're trying to design these systems.
Sure. Well, I'm not sure if there's a perfect cybersecure system. Well, there's not. But I agree on the previous comment that the decision makers need to understand the risks first. Cybersecurity is all about risk. And to be fair, we work closely both with the member states and the private sector, and during one of the discussions, one professional at one of the largest hospitals in France was like, I have a fixed budget and I need to allocate some of it to research for cancer, for example, or cybersecurity. What am I going to do? So we need to explain to these decision makers in plain terms what it means, why we need to take into consideration cybersecurity aspects even before the design phase of a system. Especially each hospital could have their own ecosystem. By ecosystem, I mean their own systems, infrastructure, the distinct set of threats. Basically, risk stems from threats and vulnerabilities to the system. So you need to calculate, let's say, an algorithm for the impact that a breach of these vulnerabilities could bring to the entity. And based on that, you need to calculate the risk. But to do that, you need to know your assets. You need to know what the data types are, why you need to protect them, and how. What is the risk if there's a breach? What is the impact to the patients? What it would mean to the entity itself? Would it cost money? Would it cost a reputation? Would it would it cost human life? It's a different. If you classify the assets based on the criticality, and then you define the risk to these assets, then maybe you can define the measures that you need to implement for the system and the entire ecosystem to be cybersecure. And then now the EU Health Data Space brings new considerations that need to be incorporated into these factors to be considered, like the interoperability, for example, or sound access control to this data, and identification of the users, both the patients and the doctors. A same language for the cross-border exchange of data. The list is endless. So we still haven't, at ENISA we are working with the stakeholders at the EU level to help ensure that the EU data space will be implemented in a harmonized, as much as possible, in a harmonized manner, so that this exchange of data would be both secure, but also to serve the purpose of research, of healthcare provision, and basically because regulation also aims to impose controls, and then if there's a breach, how to report the incident is also important. So these are also considerations that need to be taken into account even before the design and throughout the life cycle of a system. And it's not just one single project. It's ongoing and needs to involve people across the hierarchy of an entity. So yeah, there's no perfect system.
If I may, we are absolutely not in favor of moving data from the hospitals to other places. We believe that it should be the hospitals or the care providers, primary care, secondary care, that should be the custodians of the data. And we are very much in favor of federated models whereby algorithms are sent to the hospitals and only aggregated data leave the hospitals. Even then, of course, there are risks. But I think, and speaking from personal experience, what people underestimate is how complicated an ecosystem a hospital is. I mean, there are like hundreds of investigators that build their own Excel files, all of, that could be or could not be linked to the hospital information system. There are labs which have automated systems that are linked to the hospital information system, but that also have bidirectional links to the company that is done to control the system, whether the system works perfectly. And these are all open gates into the hospital system. So I would think that at this moment, the biggest danger is from the ancillary systems that are built around the hospital information system. And I think it would be needed that there are clearer guidelines on how to build these hospital information systems and what is needed, because I think that at this moment a lot of our hospitals are simply not aware of the dangers and how people could get into their system, and it's only when they've been touched by an instance that they start to realize how important this is. For example, if you look at what happened in King's College Hospital, which was one of our members, it's not a hospital system itself that was hacked. It was an ancillary system for the pathology that was actually hacked, and this way impacted on the hospital system. So I think regulation, but also help is very much needed. And I think it's not only, you need to push, it's not only pull, that's not going to work. There are so many other priorities that you will really need to push, for example, by legislation.
And Iñaki, I got the sense that you had some similar experience in this discussion of who should be in charge of the data, where should it go, should it stay within the region? I wonder if you just wanted to add a point to that, because it's a bit one level up from the hospitals, I suppose.
Well, in a case, we concentrated the data in the same system, so it is quite easy. So all the professionals have access to the same data system, and it is hosted by a public company, and it is the one that is producing and giving services for the Pascal service. So it is all levels of care, access to the same data space, and they have access to the same electronic health records. So it is easy going. The other thing is the discussion among professionals and also I'm not talking about health professionals, but data professionals, about the endless discussion about on-premise, on cloud. I think it is something that has gone right now. So the problem is much more cybersecurity than having the data on premise or having the data on cloud. So you can be even more secure if you have on cloud in certain occasions than having on premise. But I'm fully in agreement with Johan that one of the things it is there is no discussion right now. We are not going to have a European data lake. We are going to have federated lakes, but that makes sense for many reasons. One of those it is that you are going to improve the curation of the data because you have a purpose. That is the primary use of data. It is the first purpose, and you will have the intention to have good data, because that will be used to improve the care that you are given. So that is crystal clear. That is one of the things. And the second thing is, you are going to federate when you have a common purpose. And you cannot do it with the data that you have. This was the case with when we are talking about rare diseases. Crystal clear that in our system we cannot make decisions on the basis of. Well, it was funny when I was a clinical epidemiologist. Some colleagues came to me with an Excel file and they were saying, "Can you do the statistics?" And I was saying, with 10 patients, what do you want, a mean or a mode? And it is true. So it is. You cannot make meaningful decisions when you have not sufficient data. So that is when you have a common purpose. And in rare diseases, once again, I'm saying that that makes totally sense. When we have, I don't know, 50, 60 patients in the whole Europe, you see that there is a common purpose. But even in those prevalent diseases that are more converting into rare diseases, because we are talking about Alzheimer, but the other day I was in a meeting and they said, well, there are 20 types to 30 types of Alzheimer. We are talking about ALS, and we think that is just an ALS, and now there are some genetic variants that are crystal clear that have gone on the one side, but there are some others that are not so clear. So we will need to collaborate, but with an objective. And that is the basis of federating the data, and that makes sense also to the European health data space. So purposes that make things that private and public bodies will collaborate. The incentives are different, obviously. One incentive from the side of the companies, it is making money. And the incentive of the public bodies is having solutions that could be applicable in terms of improving the health of the people. So it is my question, and that was the question that I made to the commissioner before, was, what if the companies, they don't have incentive in developing some technology? So how we are going to create incentives from the side of the public bodies in terms of providing solutions that are of the interest of the general public? And I think it is something that we need to discuss together. And that also makes sense on having a European debate on which are the priorities that we as citizens in Europe have, and how we are going to preclude and conclude with those objectives together. And I'm much more fear about that. And once again, I think the opportunity is to develop systems, data systems, and local data lakes that provides, first of all, the coverage of the needs for primary use on the one side, and that change the way that we are defining KPIs at the local level, and on the other side that could enhance the possibility of developing technology that are going to change in some cases the way that we are producing healthcare for our patients.
And it's a great question, and this idea of the common purpose, I think, is really powerful. And you mentioned it directly, so thank you for doing my job a little bit. But I think I'm going to borrow your question for Mark, because the idea is, we see industry, they tend to have a common purpose. We hesitate to want to learn from them, indeed. But at the same time, there might be something we can learn in terms of how to build a collective purpose around a specific objective, because I think it would be hard to argue that they're also not the ones who are making best use of health data at the moment. So, Mark, do you think we could learn anything from the way that industry has channeled their collective purpose towards better use of health data as a catalyst for innovation?
We can learn from everyone. The point is that the industry has indeed very much done progress on exploiting data for themselves or as for their client, indeed. The point here is that there's a big difference between the industry and the healthcare sector, the healthcare provider sector, the fragmentation. And the fact, and the multifaceted interest that everyone has in this, and that means then that once again everyone needs to get something out of it. If not, the industry is capturing everything, the process will die. And if not, we need to ensure that the clinicians, the nurses, the hospital managers have an interest. This will have to be recognized, and this is something where the industry is not that. Is not facing that experience. So We can learn from them, but they have to learn also from us.
Yeah, I think that's a great way to put it. And Guillaume, I'll come back to you. I hope we haven't made your job too much more complicated today, but I've heard a lot of challenges, a lot of opportunities, and a lot of complexity. So I'll come back to you with the question of, let's say we have the EHDS implemented in the way that we envision it, and in 5 years, how do we measure that it's been a success? How do we measure what's been happening with it, that it's been used in the way that we intended? And for you, let's say in 5 to 10 years, what's the ideal outcome for the implementation of the EHDS?
Again, going back on the EHDS 1 and EHDS 2. For EHDS 1, it's more easy because it's more visible for the general population. Because EHDS 1 is really about, you break your leg in France, and you, instead of having to say, okay, I have to take all my data, French health data, and when I go back to Belgium, and they can't read it and everything here, it will be same format and everything. You can say, go to the doctor in Belgium and say, did you allow me to connect to the system and to recover all these things? And say yes, and they will get it. So that's going to be a big change for people. Again, also for some people where you have like some rare disease where the specialist may not be in your home country, but you need to go somewhere else. Instead of logging all this information, it's going to be much easier. So that's definitely, I think, it's going to be a very visible and positive win for the population in general. And for the EHDS2, it's going to take a bit more time because it will take some time for people to take ownership of the tool and to find new novel system. But I think the ultimate thing is, like, for me, the best successes would be saying, oh my God, how did we manage without this system? And I think that will be the key success driver for me. It's like, okay, we have it now, we want to keep it and we want to have it. It's really, the EHDS is really a tool. It's really there for people to use it. It will hopefully considerably lower the challenge of accessing data throughout Europe. And it's for all the stakeholders to take ownership of this tool and to develop, developing innovative use and purpose for this tool.
Thank you. And I think what I will do is give the audience one last chance to ask any burning questions that exist. And if I don't see any, I do. Perfect. So you have our one burning question.
I'm not allowed to drive a car on the road when it has not certain standards of safety and security. Why is it possible to connect an ICT system to the internet without any safety and security measures? It should be illegal, like it is with a car, isn't it?
Well, Maria, I think that's for you.
I guess that one is for me. That's a very good question, but it's not as simple in terms of implementation. We do work with cybersecurity certification principles at ENISA, and we do try to launch some cybersecurity certification schemes, specifically for example, the common criteria scheme that was recently released, but the requests come from the Commission. So it's the Commission that decides what needs to be certified. And there's also the medical devices regulation that's actually being revised currently, that requires the medical devices to be certified, to have this CE marking before they are placed on the market. So, yeah, there's not much we can do. I will
refrain from driving with my kid car on the highway.
And if I may, I'd like to add some points to the previous comments about the regulatory framework. There's a large set of regulatory requirements at the moment for cybersecurity. So one of the actions under the action plan I mentioned for ENISA is to create, to do a mapping of all the regulatory requirements applicable to health right now. So we hope that this will be released early next year. It's already at the final stages, and it will serve maybe as also as an incentive to the entities themselves if they realize what the requirements are, what the implications are when these requirements are not implemented. But they would also need some kind of incentive in terms of resources. So the action plan will also provide some resources, both financial but also capacity-related resources like exercises, trainings, awareness courses for the sector. So I think that these will also raise awareness to the health professionals and provide them with some incentives to implement cybersecurity measures.
Great, thanks. And I think because you also just provided a bit of an answer to this, I'm going to pass to Johan, then to Mark, then to Iñaki for some final thoughts. And I think I'm going to ask you the same question that I asked Guillaume, is in 10 years, what would it take for you to consider the implementation of the EHDS a success?
Well, yeah, I think if within 10 years there would indeed be an interoperable data platform that links the major hospitals in Europe and that would allow having real-world evidence, being able to access large data lakes for investing completely new entities, that would be the real success of the EHDS. Of course, I also see the importance of having the primary use of the European health data space, and I think it's a different discussion. We would also, of course, welcome this because it would also greatly enhance our capacity, especially with the increased mobility of patients. But I think there are other challenges for primary use of the EHDS. But yes, if we could, in 10 years' time, access this interoperable data lake, that would be the real success.
Well, 10 years. For me, in 10 years' time, that will only be the beginning, surprisingly. EHDS is creating the framework, is the baseline, is the starting point on which innovation will build on. Of course, that will be progressive, but if you ask me for 10 years, I would say that will be the beginning of a huge wave of innovation. And I would like to add here that we are today seeing everywhere AI, Gen AI taking up or making experience. The products are not yet mature in a number of places, but there's a lot of experimentation. In 10 years' time, the success will be if EHR systems can feed data to AI devices, to AI systems, meaning with the right quality, with the right availability, and with all the necessary conditions for AI to deliver something. If in 10 years' time this is starting to happen, then great, that will be a fantastic success.
Thanks. And Iñaki, you have the final word.
10 years' time, hopefully I will be retired. So I think it is 10-year times, and previously it has been said that something that we have right now, we were on the mission 3 years ago or even 4 years ago, and nowadays it seems to be that we cannot live without that. So when I started at the government, even the email was not I would say, a tool that was fully used. Nowadays we are talking about artificial intelligence. I think I would have loved to think about augmented intelligence and not artificial intelligence. What artificial intelligence is doing with us, it is using the knowledge that we have in terms of making fast, I would say, decisions. In 10 years' time, probably those things that we are having right now will be superseded by far because technology is going quite fast. Interoperability. We can do it right now. It is a political decision. It is a tool of investment. Yeah, I don't think we have sufficient technology in terms of saying that. Nowadays, we are considering quantum technology. So that is the next. That probably will be much useful for healthcare systems that even artificial intelligence for many senses, because it will speed up the process that we have. And for me, that I was a clinical epidemiologist and a statistician, it is an advancement. And I would have loved not to have that, but to think about that in 10 years' time, we'll have a healthcare system that look much more at value and outcomes and much less at processes and structure.
Great. Thank you. And thank you all for being here and engaging in this complicated discussion at the end of the day that deserves extra points. So give our panelists a warm round of applause.